Hello, welcome. Today we will discuss a condition known as Tetralogy of Fallot. This is our virtual theatre which helps me to present these videos. And this is my friend Ed the Avatar who helps me to describe the different lesions. Now before we start, I'd like to remind you that this video is for general purposes only. Please don't use it as a source of specific clinical information about the care of your individual child. I'm sure that you will discuss any specific questions with your healthcare team. So, let's start. First, it's probably useful to consider what happens in the normal circulation. You might want a brief refresher course on this from our video in this series about the normal heart. You may also be interested in spending a few minutes looking at the video on ventricular septal defect. Briefly, the video on the normal heart shows that the normal heart has two separate sides. The right side of the heart collects blood which is low in oxygen coming back from the body and pumps this blood through a big artery called the pulmonary artery, which then transports the blood to the lungs where it picks up oxygen. The left side of the heart, on the other hand, receives this oxygenated blood from the lungs and pumps this blood into a large blood vessel called the aorta. And from this, the oxygenated blood is then distributed back around the body. Now, something that's quite important to point out for the purposes of this video are that in the normal heart, there is no mixing of blood between the two sides of the heart. And the second is that there is no obstruction of flow from the ventricles into the pulmonary artery and into the aorta. In our video on ventricular septal defect, you will have seen that usually blood flows across the defect from left to right, as the blood finds it easier to flow out into the low resistance pulmonary arteries than into the high resistance aorta. The term tetralogy refers to the observation that this condition has four different components. But my advice is that for now, let's just talk about two. The first of these is the ventricular septal defect. The second is that there is narrowing in the outflow from the right ventricle to the pulmonary artery. In some patients, the narrowing can be so severe that there's complete obstruction or atresia of the pulmonary outflow. We won't discuss this condition today as it's often associated with more complex abnormalities of the pulmonary arteries, which cannot be adequately addressed in this short video. Let's look now at the circulation of blood in the patient with Tetralogy of Fallot and compare it with the patient with a ventricular septal defect. The big difference in tetralogy is that the blood which is low in oxygen coming back from the body and entering the right side of the heart has difficulties getting to the lungs because of the obstruction under the pulmonary valve. And as a result, at least some of it passes across the ventricular septal defect and out into the aorta so that it's distributed around the body but hasn't had a chance to pick up any oxygen in the lungs. This means that while in a ventricular septal defect, blood flows across the defect from left ventricle to right ventricle, in tetralogy, blood flows in the other direction across the defect. The amount of this blood flowing from right to left will be determined by how severe the obstruction to the pulmonary outflow is. In some babies, the obstruction can be so severe that there's very little flow to the lungs indeed. These babies can have a very low level of oxygen in their blood. We call this a low oxygen saturation. You can imagine that a baby cannot survive for very long with this condition, as there's no way to get adequate oxygen to the tissues of the body. Thankfully, survival is possible because of a communication between the aorta and the pulmonary artery, the ductus arteriosus. This allows additional blood to enter the pulmonary artery where it can pick up oxygen, which can then be transported around the body. We can now often detect this condition on an antenatal ultrasound. an ultrasound performed before your baby is born. We can usually predict on this ultrasound whether your baby is likely to have the severe form of the condition. This will allow us to transfer mom and baby before the baby is born to a maternity hospital near to a pediatric cardiac center so that we can act immediately if a baby needs our help after birth. When a baby is born with Tetralogy of Fallot, the treating team will assess the situation, and if the oxygen level is low and the obstruction to the pulmonary outflow is severe, the baby is then often placed on a medication called prostaglandin. This will keep the ductus arteriosus open and allow oxygenation. This will provide stability in a sick baby while the treating team is defining the treatment plan. What types of treatment will your team discuss with you? Well, there are two general approaches, and the precise approach varies from patient to patient and from center to center. There are advantages and disadvantages of each approach, but if we were to consider their relative merits in this video, it would be longer than one of those blockbuster trilogies, so please discuss this with your treatment team. So in one approach, a decision is made to go directly to a so-called primary corrective surgical repair. What this means is that with the assistance of a heart-lung bypass machine, the surgeon will open the baby's heart, close the ventricular septal defect with a patch, and relieve the narrowing to the pulmonary outflow tract. This often requires removal of some muscle below the pulmonary valve, some surgery to the valve itself, and the placement of a small patch to widen the pulmonary artery and outflow tract. The other way to treat a baby with a low oxygen saturation is to perform a temporizing procedure, and this will keep the oxygen saturation at an acceptable level so that the corrective procedure can then be done later when the baby's a little bit bigger. Two general approaches to these temporizing procedures can be thought of. The first is that given that the ductus arteriosus can maintain adequate oxygenation, one can maintain this type of physiology in the longer term. So your cardiologist may decide to keep the ductus open in the longer term by placing a little metal mesh tube across it, a ductal stent. This is done through a minimally invasive approach in the cardiac catheterization laboratory. Or the surgeon can create a sort of artificial ductus arteriosus by placing a tube between one of the branches of the aorta and the pulmonary artery. This is called a Blalock-Taussig-Thomas shunt. Another way to provide stability in a small baby is to try and relieve the narrowing below and across the pulmonary valve. This can be done by again placing a stent across this area and holding it open. Irrespective, the purpose of these initial procedures is to allow your baby to stabilize and to grow before performing the corrective surgical procedure at a few months of age, done in one stage or in two stages. After surgery, the severe narrowing below the pulmonary valve is relieved so that there's no longer obstruction to flow into the pulmonary arteries. The defect in the ventricular septum has been closed. As a result, there's no mixing of blood between the left and the right sides of the heart. Nonetheless, we continue to recommend lifelong care for all patients after this procedure, which is truly one of the miracles of modern medicine. We hope that you found this video informative, and we thank you for your attention.